Today is welcome everyone, and thank you for joining this webinar today as part of our Geriatric Knowledge Mobilization Rounds, hosted by the Regional Geriatric Program Central and the Gera Center for Aging Research. From a housekeeping perspective, we're meeting today via Zoom. So as guests, your cameras and microphones have been muted, and we invite you to participate via the Q&A function visible in the bottom of your Zoom screen. So if you see a question that you like, you can also upvote the question using the icon beside the question to give it a higher priority in the list of questions. And following the webinar, we invite you to participate in a survey. A survey link requesting your feedback will appear. And this survey will take less than 5 minutes and will be highly valuable for us to apply for future presentations. We wish to begin today with a land acknowledgement. I'm currently located in Hamilton, Ontario, on the traditional territory of the Mississaugas, Haudenosaunee, and Anishinaabe, and with the lands protected by the Dish with One Spoon Wampum Agreement. We also have guests joining us from across the province today, so I encourage you to reflect on the territories upon which you live, work, and play as well. So moving on to today's presentation and webinar, we will learn about the research findings that have recently been completed related to the implementation of a multi-component bedside sign to reduce delirium in orthopedic inpatients presented by Dr. Shannon Gui, as well as predicting adverse discharge destinations from the geriatric rehabilitation setting presented by Dr. Andrew Perella. So for those of you who don't know me, my name is Dr. Justin Lee. I'm a staff geriatrician at Hamilton Health Sciences and St. Joseph's Healthcare Hamilton, as well as an assistant professor in the Division of Geriatric Medicine at McMaster University. And I'll be moderating your session today. So first off, I'm very pleased to introduce Dr. Shannon Gui, who's a third-year resident in internal medicine at McMaster University. Her current research interests lie in delirium prevention, and she is a very productive and welcome member of the Delirium Research Group at the Gera Center for Aging Research. And within a couple of weeks, she will be pursuing, we're very happy that she's pursuing her continued training in geriatric medicine, pursuing a fellowship, a specialty in geriatric medicine, starting at the University of Toronto in July of 2024. So with that, I'll hand it off over to Dr. Lee.
Thank you so much for the introduction, Dr. Lee. I will just share my screen shortly. Alrighty. Okay. Thank you, everyone. Thank you to GRS and Regional Geriatrics Program Central for inviting myself and Andrew for this webinar. So today, I'm very happy to talk about this QI project that I've been working on for the past 3 years, titled Implementation of a Multi-Component Bedside Sign to Reduce Delirium in Orthopedic Inpatients. For this session, I hope that you can come out of this session understanding some of the major delirium risk factors, some of the non-pharmacological prevention strategies, appreciate the use of quality improvement methodology in carrying out this project, and then also, and perhaps most importantly, consider ways to implement delirium prevention strategies in your own local clinical setting. I have no conflicts of interest to disclose aside from the fact that this project was supported kindly by the Care of the Elderly grant from the Department of Medicine at McMaster. So to start off with some background information, in the post-operative hip fracture population, we know that delirium is highly prevalent. Specifically on the ward where this study was carried out, it was previously found to have a prevalence of as high as 30.9%. We also know from prior landmark studies that multi-component as well as non-pharmacological interventions, which address 6 major delirium risk factors listed on the slides, are effective However, they are not often widely or well implemented in routine clinical practice. And lastly, the use of bedside signage to address delirium awareness or prevention is not very well studied in literature. So with this in mind, our delirium research group set out to design and implement a bedside delirium prevention sign with the hope that it would help healthcare teams identify common risk factors, prompt staff to implement these non-pharmacologic delirium prevention strategies, and also increase delirium education and awareness. For a bit of background information, back in 2017, our group actually began to design various versions of this sign. Back then, it was maybe the size of a handheld tablet, as you can see. And unfortunately, this project was halted in 2019 by the COVID-19 pandemic. And finally, in 2021, with renewed interest from our stakeholders from the orthopedics ward, I then began to study the feedback from our prior Plan, Do, Study, Assess, or PDSA cycles and redesigned what is now the delirium prevention sign. And we were almost able to quadruple the number of signs that we installed on the orthopedics ward for this particular cycle of the study. So to dive into the components of the sign a little bit further, there are 6 key components based on evidence from the 1999 trial by Inui et al. That is fairly well known, is now known as sort of the HELP trial, or the basis of the HELP program, the Hospital Elder Life program. So these 6 components each address one delirium risk factor. For example, orientation helps to address potentially baseline cognitive impairment, so on and so forth. And the sign is designed to be this large, legible, and visually calming sign. And this is what it may look like after it has been filled out by allied health staff who are trained to fill out this sign. We also invite family members and care partners to fill out specific sections, such as the About Me section. And so as you can see, there are the 6 components of the sign, as well as an additional section about personhood, where we can learn more about the patient. And speaking of the About Me section, this might be my personal favorite section, just to give you some examples of photos taken with permission. Some of our patients and family members use it to convey a simple message of "get me home before Christmas." Others give very specific details about the patient, translations of common phrases used in, for example, Italian, leave contact information. In number 3 here, we can see the patient's sense of humor being demonstrated, married for 58 years, so hands off. And other times it's actually used by our clinical team to explain, for example, their upcoming orthopedic surgery. This is also just another visual, and you can see the difference when comparing the old whiteboards that were previously on E2 versus our current delirium prevention signs. So just diving into the methods a little bit more, this quality improvement initiative took place on the E2 orthopedics ward at the Geriatric Hospital in Canada, in Hamilton, Ontario, Canada. We implemented this project from December 2022 all the way to August 2023. And we targeted all patients over the age of 65 who were under the orthopedic service or the medicine service. Specifically, we used a tool called the Chart-Based Delirium Identification Instrument, or CHART-DEL, in order to conduct a retrospective chart review and determine whether delirium prevalence actually changed pre-implementation versus post-implementation, highlighted in blue here. And this CHART-DEL tool is a validated method for detecting the presence of delirium from a patient's chart, just to highlight that portion. With every quality improvement project, there are QI measures that we identified. And so in terms of our process measures, we looked at delirium prevention sign completion rate, whether they were actually being filled out by allied health staff, as well as staff and care partner satisfaction and knowledge. For our outcome measures, delirium prevalence was determined as previously mentioned, as well as adherence rate to the implementation of these strategies. For example, if it was checked off on the sign that the patient has glasses, is that patient actually wearing glasses when we do these audits, or have the glasses at bedside? And lastly, in terms of our balancing measures, we looked at staff satisfaction given the potentially increased workload, and that was also determined by surveys and informal interviews. Um, Looking at some of our results, this is a run chart of biweekly sign completion rates throughout the study, with individual components color-coded and the mean completion rate here in black. As you can see, there was actually a significant decrease right here around March, and also the sleep section, which is in pink here, was particularly poorly completed, and I'll go into some of the analysis of why this is the case. So to explain this big divot, as you can see, a COVID-19 outbreak along with significant allied health staffing gaps contributed to this decrease in completion, but it thankfully spontaneously recovered. And I think the other thing to note here is that even though starting in May of 2023, the ward started focusing on accreditation related topics and didn't focus on our delirium prevention sign, the completion rate nevertheless stabilized. And I think that maybe speaks to the fact that the completion and use of the sign had already been incorporated into routine, and staff were requiring fewer reminders to partake in our project. Some of the other root causes of a low completion rate are listed here. I won't go into all of them, but just to highlight the sleep section, through our surveys, we recognize and realize that the sleep component was being left to the night shift to complete by the day shift nurses. However, the night shift was expecting, the day shift to complete it. So there was a bit of an unclear division of responsibility and unequal amount of training dedicated to nighttime versus daytime staff with regards to completing the sign. So that was certainly something that was very interesting to uncover. Now, for some of the positives, what are some of the strategies we use to promote our project and increase sign completion rate? Just to highlight a few, we did conduct several engagement sessions during lunch hours, and we designed these pins called I Care About Delirium Prevention to hand out to all the staff on the ward. So this actually became very popular and is now worn by every staff on the orthopedics ward to create this sense of cohesion that this is our ward's project. We also created these adhesives with QR codes that will lead to a digital delirium prevention pamphlet and survey. And lastly, working together with the ward's clinical nurse educator, we provided feedback to the ward staff in the form of a short bulletin every 2 months, highlighting what are we doing well, what can we do better, and we discuss them during morning huddles. And then we also then develop these short educational sessions that target components that are being poorly completed. So for example, we came up with a sleep section here for sleep hygiene education. Going into some of the results, we did find that more staff were confident about their delirium prevention knowledge after sign implementation. And also, as shown in the purple here in the pie charts, many more staff implemented non-pharmacological delirium prevention strategies more often post-implementation. So I think those were all positive findings. In terms of our care partners also found the sign to be useful, as you can see in the table here, in providing care and enhancing communication. However, one interesting finding highlighted in yellow was that many pointed out that it did not improve their knowledge of delirium. And they identified that there is actually no content directly related to delirium or with delirium prevention in the text. And that sort of creates some confusion as to the purpose of the sign. So I think definitely food for thought for us in terms of the next iteration of our designs. And lastly, did it actually affect delirium prevalence? So the outcome measure of delirium prevalence was 30.6% pre-implementation and 22.8% post-implementation. So there was a non-statistically significant decrease in delirium prevalence. We also found very interestingly that when we document the confusion assessment method, or CAM, sorry, this is sort of staff documented CAM in the patient's charts. This corresponded very poorly with whether delirium was actually present. So the documentation of CAM was essentially fairly poorly done from what we found. But also interestingly, there was a nearly significant decrease in the use of physical restraints post-implementation. So I think that is a positive finding, whereas we didn't find a significant difference in the use of chemical restraints or antipsychotics. All righty. I'll end off with some of our exciting future directions for the project. So this project started on the E2 ward with several rooms. We expanded it to 15 signs, and now all 29 beds are due to get delirium prevention signs. Many other wards have heard about our project, including wards at 3 different hospitals within Hamilton Health Sciences and 9 wards. So all of these wards are now actively participating in our project and are getting delirium prevention signs. You can also find out more about our sign, which is now copyrighted as the My Care Board, on the GERAS website. You can follow the QR code on the screen there. So all very exciting. And to conclude, I think this QI project demonstrated that we successfully designed and implemented a multi-component bedside sign. It is feasible and it is sustainable, with certain facilitators and barriers as we identified and will continue to work on. And lastly, there was a signal towards decreased delirium prevalence and physical restraint use post-implementation. Some limitations include that this was a single center study, but hopefully that will change in the future. And also we were unable to adjust for confounding variables in our outcome measure, just given the sample size. So that concludes the presentation. Thank you to the entire research team. And I believe we are welcoming questions at the end of this session.
Thanks so much, Shannon. That's fantastic work. And I just had to mention that Shannon was also, for this project, she was awarded the CIHR Regin Hebert Prize for Best Scientific Presentation by Internal Medicine Resident at the annual scientific meeting at the Canadian Geriatric Society in Calgary this year. So congratulations, Shannon. So as Shannon mentioned, we're going to take questions at the end after Andrew's presentation. So, but you can definitely put in the questions now as they come, and I'll hand it over to Dr. Perella to be talking about his work related to predicting adverse discharge destinations in the geriatric rehabilitation setting.
Okay, great, thank you. So as Dr. Lee mentioned, I'm a 5th-year geriatrics medicine resident and McMaster, and today I'll be sharing you some findings from our project entitled Predicting Adverse Discharge Destination from Geriatric Rehabilitation, a retrospective chart review. So as we know, and as perhaps is becoming more prevalent in the post-COVID era, post-acute rehabilitation beds are a limited resource. So many folks enter our hospital with the hopes of going home. And we know these are the folks I'm talking about just need that tune-up before we send them on their way to be best supported by the community resources. And whereas the rehabilitation setting was hoped to be a facilitator of discharge, it sometimes is not an option for many folks or becomes a barrier. The solution to this, one possible solution, is to admit the folks to a rehabilitation setting who we are thought most likely to benefit from it, and to either defer admissions or find a suitable alternative for those who we would presume to suffer what we have termed an adverse discharge destination. And you'll be seeing this term ADD come up several times. An adverse discharge destination is simply a non-home discharge following a post-acute rehabilitation stay. So the strategy for this project was in an effort to compare patients who do not succeed in rehabilitation versus those who are able to successfully rehabilitate, and what the differences might be therein. So the study objectives, as I said, were to focus on this rehabilitation population for older adults. we assess 33 variables through our chart review across multiple different phases of care, which we'll talk about later, to try to differentiate the folks who have gone home successfully, that is, have a successful discharge, or those folks who unfortunately suffered an adverse discharge destination. As I stated, this project was a retrospective chart review spanning 1 year, so the year of 2019. This was selected on purpose, as this was, as you can tell, the pre-COVID era. I don't know about your hospital systems, but ours, Hamilton Health Sciences, underwent significant changes in the peri-COVID outbreak, and the rehabilitation unit had some changes in its service level. So it was not, for a period of time, representative of the geriatric rehabilitation services that it is back to providing now, and it had been providing. So the time date was very specifically selected. The setting was the Geriatric Rehabilitation Unit at the Juravinski Hospital, which is in Hamilton, Ontario. We selected at random 251 patient charts across these 33 variables. There were, the following slides will explore some tables that we divided based off where individuals were in their care. So this, as you can see, these are some baseline characteristics prior to even being admitted to the hospital in general. I should state that folks who come to the geriatric rehabilitation unit are either medical or surgical patients, post-acute illness, and now looking to be discharged. And these are the basic demographic informations. And then yellow in the following slides, but I've highlighted the findings that had a statistically significant difference in terms of those who had a successful discharge and those who had an adverse discharge. So orienting you to the table, patient demographics on the left, you can see of the 251 patients who charts we reviewed, 25 had an adverse discharge destination, which means that 90% of folks to our unit actually had a successful discharge. Amongst all the baseline demographic variables, a portion of which are shown here, we found out that a patient who required ADL assistance actually seemed to put them at risk of resulting in an adverse discharge. You can see the p-value was demonstrated to be significant here. The next section discusses some variables extracted in terms of the patient characteristics during their acute stay. So I pulled things like delirium on the ward, fall on the acute ward. Thankfully, these did not seem, at least in our data set, to impact a patient's ability to discharge home following rehabilitation. We sought to assess multimorbidity. As we know, there are many, many different definitions and criteria for this. We utilized the Charlson Comorbidity Index as perhaps one of the most well-studied. It itself, as a quantifier of multimorbidity, did not seem to demonstrate statistically significant difference. However, COPD, or diagnosis thereof, which is one of the characteristics of the CCI, did seem to differentiate. In a sense, folks who had live with diagnosis of COPD seemed to suffer more adverse discharges from rehabilitation than those who did not. And the final characteristic, which seemed to delineate these folks, was at some data we collected at admission to the geriatric rehabilitation unit. You can see the length of stay on average was about 17 days, so 2.5 weeks prior to coming to rehabilitation. However, again, thankfully, the time on acute care did not seem to impact adverse discharge. But the Alderman level, drawn right before patients came to GRU, did seem, at least in the logistic regression analysis, to impact or perhaps be a signal that suggested folks with a lower albumin seem to suffer increased discharge reactions at destinations. I added MSE score and PRN medications in blue just to draw attention to the fact that we often use cognitive screening or cognitive assessment to characterize folks who might be suitable rehab candidates, as well as other measures of multimorbidity, one of them being polypharmacy, so non-PRN medications being scheduled medications. Both of these, you can tell the difference of the scores are very little, and the p-values were non-significant, at least in our data set, again, did not seem to suggest that some measure of cognitive impairment or some burden of medications would have posed for patients a risk of an adverse discharge. So in summary, the key predictors from these 33 variables, a portion of which I've shown, were, again, requiring ADL assistance prior to hospitalization, a diagnosis of COPD, and a low serum albumin. Just in terms of some information what happened to our folks, and the 10% who unfortunately were not able to successfully complete rehabilitation, about 70% were required to transfer back to the acute care ward, either for medical or surgical issues. One patient was transferred to the ICU, two patients were transferred to the ICU, and one patient in our data set passed away while on the rehab unit. So this leaves just some conclusion, maybe some thoughts for discussion moving forward. So healthcare teams sometimes hesitate whether to admit older patients with complex medical issues to rehabilitation, favoring them perhaps at the outset, but perhaps prematurely as non-rehab candidates. However, despite the commonly perceived barriers, most patients actually did very well and had a successful discharge home. Barriers, in quotes, things we kind of think of, polypharmacy, multimorbidity, lower cognitive testing scores, falls, long length of stay, things that we often assess in our rehabilitation assessments of folks, themselves do not seem to be barriers. And therefore, I'm proposing that it's important to remain critical when deciding which factors we're actually using to determine a patient's rehabilitation candidacy. And that is my presentation. Thank you all.
Thanks so much, Andrew. Congrats on the great work. And I also wanted to mention that if you wanted to read more about Andrew's work, he actually has this project published in the American Journal of Physical Medicine and Rehabilitation. So I just invite, we have a couple of minutes for questions. If anyone has any questions, please place them in the Q&A box. And we'll start off. We have a first question for Shannon. The comment is very impressive presentation. It's great that you see expansion to the other sites. Is there any particular method that you use to disseminate and engage other sites? And I'm going to add a little bit onto that. Is there any differences in how you're tailoring it to the various sites in terms of board?
Right. Yeah. Thank you for the very interesting questions. So I would say, in short, I certainly cannot take that credit by myself. Our team has been excellent in helping disseminate the information. I will specifically shout out our help team here at HHS, Yasmin, Khalili, Alex Kirkovich, and the rest of the team. So I think in one way, there is some top-down dissemination in the sense that Yasmin and Alex often have opportunities to present about this project at to administrators and so on. So there is dissemination that way, and then through that top-down method, the administrators hear about this project and become interested in developing this for their ward. There is certainly also sort of a bottom up or sort of word of mouth through the nurse managers of each ward. And I think that's how we got a lot of the wards at the Juravinski. As it started at E2, people heard about it and people were interested to develop it for medicine and hemonc and so on. So I think through both of those methods and through our amazing team, that has been quite successful in terms of the tailoring. Certainly, we've put a lot of work into communicating back and forth with the wards in terms of their needs. So an orthopedic ward would, want the mobility section, one can imagine, probably much more than the medicine ward. So how do we use that space effectively? The hematology oncology ward specifically requested a chart where they can write down blood counts. So, I think that's just through a lot of communication, meeting with thinking about is there evidence behind these? If not, what makes sense, what is practical, and then going from there.
Great. And Andrew, we have a question for you. One of them is, I think, two questions for you. One is a clarification. One person asked whether any of the patients required long-term care as a discharge destination. Maybe we'll start with that, and then we'll add the second question.
Certainly, the criteria for this rehab unit was that a patient had a discharge destination for home, which was either home and community or retirement home. If their trajectory was for long-term care, they at the outset would not have been a system level applicant for a rehab unit.
Okay, and the second question was, you identified patients with low albumin as being one of the predictors. Do you know if these patients received nutrition assessments or counseling or supplementation either before or after their admission to the rehab unit?
The data from before the rehabilitation unit, based off our extraction, wouldn't have been reliant enough to be able to say where they had a nutritional assessment, because it's not always documented, or it maybe happened after the consultation. On the rehab unit, all patients are seen by the dietitian, at least in 2019. Things may have changed now, but they all at-risk patients were identified on the rehab unit.
Great. And Shannon, another question for you. One of the audience members was wondering if the health volunteers had any role in the education or rolling out the project, and did they play a role in maintaining or updating the whiteboards? And the second question was whether a lot of the other additional materials that you have, are they available to other sites like the delirium prevention pins and posters and sleep aid materials?
Right. Great questions. So in terms of the health volunteers, they actually did have a role in our project. Their role was actually as auditors for our sign completion rate, as well as one of our outcome measures, which is adherence. So whether they had hearing aids or glasses at bedside. So the health volunteers were recruited to help with that part of the project. And then as these health volunteers are often high school students, interested in healthcare and so on, hopefully it also gave them some background and education on delirium as a whole. Speaking of that, the question actually maybe inspires me to just design a feedback survey for our health volunteers and see whether this involvement was helpful for them. So in terms of the second question, currently the materials are not available. They were, when this project was much smaller scale, they were just designed, on my laptop and sent off for these pins were for sort of sent off to order. So now that it is much larger scale, I think we will need to do much larger orders and sort of have a method of disseminating to all the wards that are involved in the project. But if you're interested, please feel free to contact me and I can certainly provide some.
Great. And just one last question. To Andrew's a clarification question related to the discharge to long-term care. When the patients were discharged to medicine, do we know how many were due to medical reasons, or if the discharge home was not feasible, went to medicine in an ALC status because the audience member feels that the latter might look very different in terms of indicators to predict an adverse discharge destination.
Okay, and I guess unilaterality of the webinar, I'll assume, I was going to clarify one part. What we're seeing these days, maybe I understand correctly, the folks end up on rehab, but they're deemed ALC and go back to medicine, and that is currently a roadblock. We're working to now that they were not brought back to the medical ward for acute medical reasons, but actually just a disposition, we'll say, as much as we don't like that word. In 2019, the data we pulled, and we actually found the reasons they required return to medicine were all acute medical issues, and about 50% were that. Climate has changed these days, and I appreciate that we label them as return to medical ward, but actually they did find it was just a systems issue. At the time, half the patients required an increased level of care or super monitoring or therapies that were not available on our wards to safely administer.
Well, thanks so much for everyone for joining. I'm conscious that we went just a couple of minutes over time, which is great because it means there's a lot of interest in both your works. I just want to congratulate both of you on your work and thank you for taking the time to share that with all of us. And just to the audience, if you have any additional questions or trying to find out where how to find out to read more about Andrew's paper or to get materials that Shannon might have designed. You can both reach them at shannon.gui@medportal.ca and andrew.perella@medportal.ca, or you can reach out to the RGP Central or the Geriatric Center, and we'd be happy to give you their contacts. So with that, I hope everyone has a great day and everyone stays cool with this heat this week. Thanks so much.